The patient is a late middle-aged man with a clear, not totally soft cataract. A Rhein diamond 1.2 to 1.4 is used to make a nearly vertical incision to the right, and then a nearly horizontal incision to the left. This is a 3D blade which is self-directed, giving us an appropriately length incision without directing the blade. Viscoelastic is used to express aqueous humor, and a microincision Capsulorrhexis Forceps is used to create a capsulorrhexis. These forceps allow for extreme precision in the performance of capsulorrhexis and great stability of the anterior chamber, since the chamber is totally stable with respect to the viscoelastic present in it. We don't find, as we do through 2.5 millimeter incisions, that capsulorrhexis is accompanied by expression of viscoelastic through the larger incision. And we can see that this technique requires finger movements only. It is impossible to use one's wrist while making the capsulorrhexis, and I think this leads to somewhat greater reproducibility and precision in the performance of capsulorrhexis, since we are considerably more dexterous with our fingers than we are with our wrist. We can see that there is a pre-placed mark on both sides of the 90-degree meridian, extending from the limbus quite posteriorly on the sclera, or the conjunctiva overlying the sclera, which will aid us in the alignment of our instrument for creating arcs on the cornea periphery to relax the steep meridian and correct pre-existing astigmatism. This capsulorrhexis is approximately 4.5 to 5 millimeters in size, and it is quite round, as you can see. We now perform cortical cleaving hydrodissection, being careful to not, at the first fluid wave, express the lens from the capsule. This is gentle, continuous pressure. We then depress it a little bit in order to try and get some cortical cleavage. And then we create a hydrodelineation as well to separate the nucleus, the epinucleus, from the endonucleus. We now insert the phaco tip to the right and have the bevel pointed toward the equator of the endonucleus, and we place the irrigating handpiece in the left paracentesis and keep it by and large on top of the nucleus so that it is almost impossible to traumatize the cornea. It is obvious that with the right hand incision almost vertical and the left hand incision almost horizontal, we are going to be able to coordinate these two instruments in a slightly more efficacious manner than if they were both made in a radial configuration. And we can see we use almost no ultrasound energy, even though the endonucleus has a little bit of substance to it. Most of the refractive lens exchange procedures done on patients with clear lenses are done almost exclusively with fluidics rather than a combination of fluidics and ultrasound. We're working here at the level of the capsulorrhexis, equidistant from the posterior capsule and the corneal endothelium, and of course the corneal endothelium is coated with viscoelastic and is protected from just below by the irrigating handpiece. We can see the ease with which we can coordinate these instruments as we move the epinucleus now out of the capsule and try to flip it. In spite of the fact that it was a clear lens, it is not as completely malleable as a clear lens in a younger person, and we can see that there is some substance to the lens material here. The epinucleus is now flipped and removed completely, and as you can see in the parameters to the right on the video overlay, we've used an effective phaco time of 1 second with less than 1% average phaco power. We leave the irrigating handpiece in the eye and bring the aspirator in from the right so that during the procedure we never allow the vitreous face to trampoline. This is of course important in myopes because we would like to keep the vitreous face as constant in its position as possible. We fill the bag with viscoelastic and then use the Rummensen astigmatism marker to mark on the cornea the arc length of the steep meridian that we're going to incise with limbal relaxing incisions. This is the Cybele LRI knife, which is capable of being set for depths of 500, 550, or 600 micron depths. The Rhein 3D diamond trapezoidal knife is used to make a 3.5 millimeter incision between the two side port incisions through which we will insert an Ionix crystal lens. The lens is grasped over the optic and onto the leading haptic as it is delivered into the capsular bag, after which the trailing haptic is purchased at its proximal end and delivered into the capsular bag as well. We will see in this case that it gets caught on the capsulorrhexis, and we can nudge it directly into the bag easily as long as we depress the optic a little bit and push it forward as we nudge the trailing haptic into the bag. And we see that once that's done, the lens pretty well self-centers. We now use coaxial INA to remove residual viscoelastic from both the anterior chamber as well as the posterior chamber. And we see that at the completion of the case, we will have an absolutely spherical cornea. We do not use miotics in these patients because of the need to keep the ciliary body at rest, and in this particular instance we are going to inject a piggyback IOL because the patient had sufficient refractive error that the power of the crystal lens was not adequate to address the entire spherical equivalent. This is a Clariflex IOL being injected into the ciliary sulcus on top of the capsule in order to give a full correction at distance. And of course the movement of the crystal lens within the capsular bag after the eye recovers from cycloplegia will allow for an amplitude of accommodation.